Thank you all for doing that. Really appreciate it. So, real quick timeline where we're at. So, you all did wonderful job at the RFA that was made available on March 2nd and then due on March 20th. And then you all sent the RFP on April 13th, and we're here today at the RFP Q&A. And then it is due next Friday, May 1st. After which we'll go through about a 2 to 3 week scoring period internally, and then the notice of award would be May 29th. The contract would be issued at the beginning of June, and we'll do another Q&A session there. And then the whole contract is a year long, starting July 1st, 2026 through June 30th of 2027. So a little bit about Swatch. Our mission is dedicated to the pursuit of health equity by addressing the barriers that impact well-being in Clark, Klickitat, and Skamania counties. Through collaboration, innovation, and community partnerships, we drive sustainable solutions that promote health and wellness for all. We are located in Southwest Washington. We cover Clark, Skamania, and Klickitat County, obviously. We're part of a 9 ACH Accountable Communities of Health group. You can see the state split up there. We're funded under Washington's Medicaid 1115 demonstration waiver, MTP 2.0, through the Centers for Medicare and Medicaid Services, CMS. And that's what would be funding this project, the funds related to health-related social needs, HRSN services. So that HRSN services is talking about addressing unmet adverse social conditions that contribute to poor health. These needs may include, but are not limited to, like food insecurity, housing instability, unemployment, lack of reliable transportation. And so as part of that, we developed a community care hub. As part of our funding requirement, we developed a community care hub. Swatch's community care hub is called Health Connect Hub. So I'll say the hub or Health Connect Hub or community care hub, and we're referring to the same thing. The goal for that is to provide free, low-barrier, community-based care coordination services to increase access to needed services, reduce cost, and improve social determinants of health, with the goal to amplify and coordinate the great work of established local community-based organizations such as yourself. And so this program is designed to connect these trusted community-based organizations with the administrative coordination, the funding, and the training and tools that Swatch provides so that we can offer local and culturally appropriate one-on-one support. I'm not good in presentation mode, so I just kind of leave it off just so see there. What we're talking about when we're talking about community health workers who we're funding, they may come by different titles, by different organizations. But when I say CHW, I'm really referring to community-based care coordinators, peer support specialists, navigators. They may be similar titles depending on your organization. But the goal is to build trust and provide culturally responsive support and connect community members to resources that meet their needs, helping community members navigate complex health and social service systems. A lot of what we do is really structurally based around whole person care. And so that concept is recognizing that the best way to care for people with complex needs is to consider the full spectrums of needs. Beyond just what a particular agency or entity might be providing at that time, and trying to address somebody's full spectrum needs over the course of time. So when we get kind of the nitty-gritty of it, this navigation program is designed to fund CHWs and supervisors at community-based organizations. It is try to assist people no matter how or where they first seek help. That we apply that theory of no wrong door, wherever somebody is coming to receive services, that they can get connected to services. A big part of this program is screening for and connecting to services for clients to address their health-related social needs. It's very much client-centered care coordination, and the CHWs help bridge that gap to community members to engage with health and human services. So it's very much equity-centered. All of our programs are really focused around low barrier. As long as somebody lives within Clark, Skamania, and Klickitat County, or is moving soon to one of those counties, then we consider them applicable for many of our programs and navigation as well. And so the navigation caseload size It's around 40. We're really trying to hammer that out, but it is going to be at a minimum at least 40. The episode of care for this program is around 6 months or less. The We're not a strict enforcer of that, but that's generally what we're looking for in the total episodes of care within this program. Um, and then the priority populations is youth, and that would include up to 24 years of age, and reentry. So within the navigation program, um, Swatch's Health Connect Hub would provide funding to support capacity building, navigation CHW, and supervisor FTE cost reimbursement, direct program costs, indirect costs. And then we do provide a lot of training. It's a big part of what we do. We really enjoy the training portion of it, and the core of this training would be provided by Swatch at no cost. We do a lot of technical assistance and customer support and networking. We've developed a network of dozens of agencies and bringing people to the table. Some of them are contractually partnered with us, and some of them have informal relationships and show up to monthly meetings, and we all try to solve big problems in the community. And so it's a fun group. I think the networking piece is an exciting part of this program and this relationship. Talking about contract workflow. Y'all did the RFA, and now we're at the RFP. If selected to participate in the navigation program, it would be a 2 phases. One is the capacity building, and that's the first 3 months of the program from July 1st, 2026 through September 30th, 2026, and up to 25% of the payments would be of the total contract would be available during that time. In our mind, we're still a little bit trying to structure it, but it would be like sign the contract, 5% of funds is released. Hired CHWs and supervisors, a certain chunk of the funds would be released. The idea is to make sure that your agency is ready to move to the service delivery phase and focused on capacity building during that first 3 months. The second phase is an amendment to phase one's contract. And if the phase one's obligations have been met, and then we move to the service delivery. So that would be 75% of the contract funds, and that was based off reimbursement based for CHW and supervisor FTE. And that's the ongoing service delivery case management. A lot of that phase will involve continuous quality improvement. When we talk about that, mostly we're talking about reporting and how we use benchmarks within the programs to help guide CHWs and agencies towards success. There's a lot of trainings that go on throughout phase one and phase two, but certainly with phase one of the important parts is that the CHWs are hired and maybe they're at the minimum scheduled for that training. So a lot of the training may occur for your agency within phase two. And then cohorts is those monthly relationship building that may include both the formal people who are contracted and then also informal partners within the community who want to learn about resources. So just to reiterate, phase one is the structured 3-month capacity building period, and we're working to ensure agencies are fully prepared to deliver that high quality navigation services. And so focused on staffing and supervision readiness, training, onboarding, data system integration, a lot of the reporting and the client management system we use to operate this program. And a big part I just want to call out too is establishing internal workflows and compliance structures, definitely around an internal referral structure. If it's new for your agency, your entity to, how do we identify clients that may be coming in that would be applicable for the navigation program? That's something we definitely would want to have hammered out and documented within phase one, within those first 3 months, to make sure that there is internal referrals within your organization being flagged and given care coordination, the opportunity for care coordination. Phase two is the service delivery. It's the meat of the contract and the meat of the program. and that's where 75% of the remaining reimbursement-based funding is found. We do this, every agency is at a different place. And I should say capacity building that first 3 months, maybe less if your agency is transferring an employee internally and supervisors internally to support the navigation program based off what you're allocated. You may be ready to move to service delivery quite quickly. And so we just want to make sure that that you have the infrastructure there to begin that service delivery. And that helps us be responsible with our funds and how we're funded through the Healthcare Authority and 1115 grant. So talking about funding, I know I'm cooking through this, but happy to answer any questions throughout, and please feel free to throw them in the chat. This is based off what is total FTE awarded for the contract, but a CHW can receive up to $91,000 per one FTE annually. That would be inclusive of salary and benefits. For this program, your agency can request up to 4 CHWs, and they may be requested in increments to the 10th. We are trying to give maximum flexibility to your agency or to your organization and what you're trying to set up. Very much rooted in, is this possible? And we'll talk about the exhibits and making sure that you can meet the program. When it comes to supervisor, that is reimbursed at a rate of $25,000 per 0.2 FTE supervisor annually, inclusive of salary and benefits. So that would be, if you have, you can request up to 1.0 supervisor FTE, and again, in increments of a 10th. And so annualized, or like if you applied for a full supervisor FTE, it would be $125,000 that could be reimbursed to the agency, just to kind of do the math there. And then direct costs. The next slide will really help put this into a table. I think it'll make a little more sense. But direct costs is up to $7,500 per one CHW FTE. And then all of those amounts, the CHW, the supervisor, and direct costs, then we add the indirect costs up to a rate of 15%. So if we take this theory here and we apply it to an agency that is wanting to hire 2 CHWs and wanting to hire 0.2 of a supervisor time towards the navigation program. Those 2 CHWs would be supported at $91,000 times 2 for $182,000. The supervisor would be at a rate of 0.2 FTE for $25,000, and then $7,500 worth of direct costs to support the program for those 2 CHWs for $15,000. So the subtotal there is $222,000, and then we would add 15% towards indirect rates. So for a little over $250,000 for that contract. When we think of how that is delivered, there would be up to 25% of that would be available during the capacity building phase. And then the majority of that would fall under phase 2, the service delivery phase, in a reimbursement rate style. There are, I see the question in the chat, there is no budget requirements for the RFP application. There's no spreadsheet there. There is a lot of questions that ask about how you can support it from a financial and admin and overhead perspective, but there is not a spreadsheet as part of this RFP. So, submitting the proposal. A complete application will include both Exhibit A and Exhibit B. The Exhibit A is unscored, and it's really focused on like minimum requirements and making sure that the organization has the infrastructure and has a good plan in place. Exhibit B is really scored, and the focus of most of the scoring, and we'll talk about that a little bit. There are 4 options to submit this. You only need to choose one. The primary option, which I kind of assume most people will use, is the job form. And let's see here. So that that looks like this. There you can download the RFP at the top of it. It has Exhibit A and then Exhibit B. If you are filling this out and you're like, wow, this is a lot of questions, you can scroll to the bottom and save it, and it sends you a link. So that's, I would imagine most people kind of use that option, but there's nothing, there's no, there's nothing punitive if an agency does a different option. When y'all were sent the RFP earlier this month, there included a Word version of Exhibit A and Exhibit B. Of course, you can email those as completed submission to myself and Morgan, who's the contracts and grants manager at Swatch. And then there's an option to do a video submission, and this would be up to a 90-minute video of answering the questions, and in the same order that they are within Exhibit A and Exhibit B. The last option would be the interview submission. In the original RFP, we were hoping that if anybody that wanted to do the interview would ask and submit us a request by Friday last week. If you want to do the interview, we're still open. So you just have to interview myself and Morgan Middlestott, a request by the end of today, and we can get something on the books for next week. In that case of the interview, it's recorded, it's virtual. We're asking the questions as they're outlined, and there's not any sort of like follow-up questions or anything like that to make it as fair as possible as we can. So those are the 4 options there. And again, the completed application does need to include Exhibit A and Exhibit B. When we talk about Exhibit B, the scored portion, the meat of the RFP, it's got 6 sections. There's several questions in each of those sections. Section F is really about the priority populations, and so we're trying to see if your agency can attest to they currently operating a program or programs and maintain partnerships that prioritize supporting newborns and children and youth and young adults up to 24. And then a similar question related to individuals reentering the community after incarceration. So what that would look like for scoring wise, it's a 25 points per question that would be tacked on to the total amount of weight available to an agency. In the JOT form, it would look like this. And so you would say yes or no, and receive 25 points or not based off if you fit within that parameter of serving young newborns to up to the age of 24, or similarly down here, yes or no to whether you serve individuals reentering the community after incarceration. So, scoring the proposal. So May 1st, next Friday, you all submit a proposal. Myself and Morgan will do a minimum requirement review that will include Exhibit A and Exhibit B. And then we'll move into an internal Swatch review panel, which will be about 4 to 5 Swatch folks. We'll just review Exhibit B. We also have a wonderful infrastructure of the Health Connect Advisory Council or committee. I always could get those confused, but it is a group of community members that is led by Swatch's community engagement manager, my coworker, Mercedes Aller. And she has developed a subgroup of about 30 individuals that can help us, 30 individuals from the community, from community-based organizations that can help review these as well. So a really awesome opportunity to get a community perspective and perspective of people that are doing this job similar to yourself. They will review Exhibit B, and then after the internal Swatch review, and then a review by the Health Connect Advisory Council, we would bring those scores together and look and see how do they compare? How does Swatch's internal review compare with the Health Connect Advisory Council? Is there a misalignment? We're hoping that there's not. There is Swatch within the RFP reserved the right to do a finalist oral presentation we would call upon your partners if we did this, and then just answer some questions. There's a little bit more about that criteria within the RFP, but the meat of it is the Health Connect Advisory Council reviewing and then an internal Swatch review. And then Swatch would make the final decision based off a lot of what is in Exhibit B. You can see the evaluation table here. So those priority consideration questions we were looking at earlier, those would be up to 25 points each for down here. And then the sections, the 5 sections above that for experience, staffing, service delivery, tech and security, and financial management and infrastructure. All right. That is what I have for this presentation. I'm happy to go back to slides or answer any questions. I have a copy of the RFP here. We can pull and look at that if there's any confusion there.
Savi, there's 2 questions in the chat right now around the budget. Do we need a budget for the RFP application? And if so, how does it need to be submitted?
You don't need a budget for the RFP. We're kind of doing a one-size-fits-all when it comes to the amount awarded, and it would be based off FTE, and it could be proportioned depending on how what type of program you're trying to run, if you're trying to do part-time or full-time CHWs or supervisor. So no, there's no budget and portion of the RFP. All right, y'all can raise your hand, throw it in the chat. Swatch's client management system, is it compatible with HMIS? So the question is, can we speak a little bit more about Swatch's client management system? Is it compatible with HMIS? So it's a separate system than HMIS. The client management system we use is called Care Coordination Systems, or CCS. Sometimes we refer to it as the Community Health Record, the CHR. So a lot of different acronyms to describe the same thing. It is a helpful documentation tool that allows supervisors to assign clients to CHWs based off their capacity or best fit. It also allows us to take in referrals and then assign them out to your agency. So it's a platform that is managed by us at Swatch, and then CCS is a contractor. And allows us to assign referrals to you all, and it's a bi-directional flow. So if you're at capacity or you have somebody that may be a better fit served by someone else within the network, you could send us referrals. So supervisors go through and help enroll clients with the CHW as support is needed, and then make sure that the documentation is correct after CHWs provide the care coordination. For a CHW CHWs they would document contacts, and they would document a lot of the care coordination efforts within that platform. Gabe, can I reach out to you? I don't think it's compatible with HMIS, but I would like you have a little more technical side of the.
It is not. So if your team is required to use HMIS, you'll have to double document, unfortunately. Which we have other teams that have to do that, and it works okay for them. And if you have questions about that, we'd be happy to connect you with them and see how things work.
Yeah, so that's definitely something to think about too. Being a part of the navigation program does mean you have to use does mean you have to use our client management system. So if you have internal documentation, that could be a double documentation requirement for your CHWs, and it's something to consider with this. We, like Gabe was saying, Gabe Peretti, he's the Swatches analytics networking tech guys. Wonderful customer service person and just runs a lot of the reporting from the back end. So a really big help for the Swatch crew. I lost my train of thought.
I have that effect on people. I do see
Yes.
some hands up.
Yes, yes.
I think
Kimberly.
Ren had her hand up first.
Oh,
Yeah.
sorry. Please. Ren, what do you got? I see the question in the slide. Will you be making slide deck available? Yes. Yes. And we're recording it right now. And so the goal is to make that recording available as well. Ren, I don't know, we're not hearing from you. But I'm going to pass to Kimberly. We'll circle back.
Sevi, with our the 7,500 per FTE for direct costs, will that automatically be awarded to folks? In the past, we don't typically end up using a lot of those funds, and I like that they're available in case something develops where I am going to have some costs. But do you prefer that we put them in and then return them unused, or should we not ask for them so you can use them for some other purpose?
So it's a good question. So Kimberly works at Child and Adolescent Clinic. They're currently a Pathways partner, which is a separate program that is also falls within the Health Connect Hub and part of this network. And so the question is about direct costs. For this contract, we would award $7,500 worth of direct costs. If you didn't expect to spend that, we can certainly reduce that budget and allocate it appropriately to different agencies or different programs. Our hope is that that funding is used in a lot of ways to support the program. And so that could be outreach. It's going to look different, but certainly we could reduce that amount, and then that would be more in like the contract phase of this when we think about June is really when we would be getting into those numbers and finalizing budgets. But we're kind of going with more of a one size fits all model for this program, and so just by having, let's say, 2 CHWs awarded FTE, your agency would see that $15,000, and then we could always reduce it as needed to fit your agency.
Thank you.
Is my mic working?
Yeah.
Oh, yay. Okay. Sorry. I wanted to say that Outsiders In does that HMIS and care coordination system duplicative work, and we would be happy to share how we go about and what we track in which system that helps us meet both contracts.
Thank you, Ren. Was Grace next?
Yes, and thank you, Ren. That's good to know. I am hoping for a little bit more clarity on what you consider a caseload. And the reason I'm asking, we are looking at supporting a reentry program that we have. And our coordinators for that program, they don't necessarily have an ongoing caseload. The way it functions is they're really looking at doing assessments and referring to outside programs in the reentry program, if that makes sense. So I'm wondering if that's compatible or if we need to kind of rework that.
What does the episodic care look like for how you envision that program? Like from the point of how long do you imagine that interaction would be for a care coordinator who's intaking somebody and, you know, providing some sort of support and directing them to
Yeah, that's a good question. So our coordinator, they co-locate at the Clark County Jail as well as at our location. So they are working with folks in the jail and doing assessments and sort of, you know, assessing what they need and what they're eligible for when they get out. And then they are available to connect with them after they leave the jail as well. So it really varies. I'm not sure I can give like a timeline on each one. And they're helping with that system navigation, but they're not necessarily like in a caseworker role necessarily. So they're not working with this person for months and months at a time. They are assessing their needs and then connecting them to service providers.
Okay. From what I'm hearing, I think it could fit with, I think it does fit within this model. If anybody from Swatch has a different perspective, please let me know. But it sounds like you're working with a client base before they are released, and so there's some screening there, there's some care coordination there, and then a referral to the necessary services. But a period of at least a couple weeks. Is that fair to say?
Yeah,
Okay.
They just don't have like a caseload in the traditional sense, but they're certainly serving more than 40 people a year.
Okay. Yeah. It sounds like it fits. We do, you know, look to enroll clients, but that enrollment criteria is very low. For this program, we're trying to make documentation requirements as low and as simple as possible while still meeting our funder requirements. Our funder does, you know, have us do a screening process, and then, you know, moving to enroll the client and continuing to address their needs, identify goals, and assign them out. So I'm hearing a lot of compatibility.
Okay, thank you.
All right, Claire.
Yeah, good morning. I wanted to just double check on your youth priority population. We do serve youth, but we serve a portion. We don't, you know, serve newborn through. And I just wanted to make sure that we're focusing on middle school youth at one location. So I just wanted to make sure you don't have to serve like the entire continuum of that, correct?
That is correct. Yeah, you're right. I'm just pulling up the RFP because it lays it out a little bit more. So for that section, which would be eligible for 25 points towards the score, sorry, it's split between 2 pages. So it currently operates a program that prioritizes newborns, children, youth, and young adults up to 24. So yes, it should have been an and or young adults up to 24, but it sounds like serving that middle school, you would be, and certainly currently maintains partnerships with schools that you would fit within that criteria.
Yeah, and then the other sort of part of that question, you know, I love the bidirectionality of this, you know, hub. My organization does want to sort of check in how that might work for our situation because we are embedded on just that one middle school campus so far. We do have our eyes on the elementary school before it and the high school after it, but that's not where we're at yet. How would that work if, you know, we would be pretty easy to send out referrals to families that need food support or justice system support, but we would have a harder time accepting referrals unless the student was at that middle school or intending to, you know, transfer to that middle school. How do you think that format would work in this network?
I think that a singular school may be a little bit of a restriction for this program. Do you mind if we follow up after? Do you mind if, I think I have your email, so do you mind if I reach out to you after and we can kind of talk a little bit more specifically about that?
Yeah, I think we've got a chain email going with me and my leadership. Keisha Roper is here today. So I can bump that up to the top of your inbox maybe, and we can take it there.
Okay, thank you so much.
Okay.
To kind of provide a little more context on our funder requirements, within Swatch is paid proportionally by the number of Medicaid lives within our region, and the Healthcare Authority, our main funder that kind of distributes that 1115 grant, they want us to reach a certain engagement rate within the population, and so our programs are generally open for all, and the referrals is definitely a similar type approach. And we want to make sure that somebody who, if we receive a referral, that we can assign it to the appropriate agency. And so sometimes limitations on what agencies are able to accept can be a little bit difficult. But just to kind of provide a little bit more context on how we interlay within the state of Washington.
I think my question is a jump off of that question.
Okay.
I know like our outreach teams, they, we focus on usually 18 and above, like 18 to 24, but we also find families and couples and different things like that to where it might not be our priority, but we have capacity, to support. Is that it? How, I know in the questions it just had like yes or no's. It didn't have a space for nuance on that question, and so I felt awkward in what that answer might be, because it seems like it had more explanation needed on that beyond just yes or no. But I mean, if it's not necessarily like our thing but we do take the cases as they come to us in both youth and then also into from reentry. I don't know. Is that something that would still be yes or no, even though it's a probably?
It does sound like a probably type answer. It sounds like
Yes.
you're kind of open to all ages and somewhat serve them all equally. Is that a fair, maybe not fully equally, but would you say that most of your programs are available across the spectrum of age? In the red.
It am I having tech issues still?
I don't know. Would you say that your programs are like kind of equally serve ages 18 through, I don't know, however old somebody may be?
Yes, we absolutely do. We're not specifically a youth program, and we're not specifically a reentry program, but we do support people who are, who are younger, getting them in connection if they are experiencing homelessness in that framework. We try to make sure that we get them to the right partners that have more specialty on that.
Okay.
But yes, we are open to either of those populations, but we are also not that is not our number one priority. It's the tucked in part of experiencing homelessness that becomes the priority pool in our case.
Okay. And I think that's a amazing way to run a program, and clearly OI does amazing things within the community. I think for the sake of that yes, no question and serving, like prioritizing those populations, those young people, what we're trying to drive at is like programs that are more specifically oriented towards that there's staff capacity and programs that are really directed towards newborns through age 24, and however your specific agency may be serving them. Does that make sense? Yeah.
It does. It does.
You're still amazing.
Thank you. No, and I don't want to in the search for points as we look through that, it was just wanting to make sure where we did fall. Thank you.
Yeah, of course. I see a question related to letters of support. They're not part of this, the RFP review process, so they should not be included for this. What other questions? Of course, you can email myself and Morgan, and we will respond. If you have like a more specific question to your agency, or maybe not, this isn't quite the setting to ask all of that, you can we'll hang around here for as long as possible. So, any other questions, any other lingering thoughts, anything confusions? Are people having any problem accessing the jot form or saving it? Anything like that?
I do have a follow-up question around this security risk assessments.
Okay. Mm-hmm.
I guess I'm curious at what level. I know that there's a few different types of risk assessments. I mean, or is it just a broad-based?
That is a good question. I would defer to Michelle. I don't think that was her. I don't think that was coincidental, but just a joke. So I apologize. I would have to get back to you on that.
Okay.
And I know the question you're talking about. So definitely what would qualify as a risk assessment, or when does the last one be? Details. Would it be safe to say that answer would be applicable to everybody, that everybody would want to understand that risk assessment question a little bit more and should include on that email? Okay, all right. I'll shoot it out to everybody once we have a clearer answer on that. Sorry that it wasn't clarified within the RFP. All right. This kind of ends the formal part. And if anybody that wants to stick around with any questions, please do so. The recording will be made available as soon as possible, and with some follow-up questions that we'll include in the afterthoughts of this with the PowerPoint. Swatch crew. Yeah.
In the sections where you say Exhibit A,
yeah,
keep responses under 250 words. However, there's
yeah,
no penalty for exceeding.
Yeah.
Are you saying you want Exhibit A to be the entire exhibit to be less than 250 words?
No. Each section.
Okay, very good.
Yeah. Or each answer. And
yeah.
There is no extra points for brevity, although I would love you for that.
And what's the other question? I have the exhibits and the RFP printed out. I'm assuming there's a begin to fill out the application. There's a link to use the jot form instead. Oh yeah, here it is right here.
Yeah.
Never mind. It's on page 11. All right, thank you.
Yeah, and in the main link to from the email I sent out to it also is in there. So we'll include that in that follow-up email after this as well. Any other lingering questions we can answer? We can talk about some of the training that a CHW would be offered in this program. We can talk about what that onboarding can look like. What would be helpful, folks? What is kind of missing from your end? And maybe workflows that are not quite clear for this program, or what does capacity building support look like for phase 1? What would be helpful?
I think understanding, some of us have been in the pathways model and have been utilizing the care coordination system for that model. And so understanding that we are going to be continuing with the same system, I guess making sure that we have an understanding of what forms. Are we going to be utilizing modified forms for this, or just, different timelines? I guess I'm still curious on how how that difference is going to look
You asked the good,
in the yeah.
You asked the good questions. A lot of it is very similar. So Pathways is a program that's also within the Health Connect hub that Swatch operates. There's 9 partners within the Pathways model, and about 40 community health workers are funded through that. We talking about a little bit earlier ago, like trying to reach a certain engagement rate within the community, that led us towards the navigation program. So Health Connect Pathways tends to be a little bit more long-term. There is no episode of care limit that would be enforced within the Health Connect Pathways model, while navigation is more short-term. So the caseload may go up to 6 months. We're not hard and fast on that 6 months, but that's kind of generally what we would think would be a max episode of care length. The social determinants of health screening for Pathways is more comprehensive. It's a little bit longer. For navigation, it's shorter. It's more streamlined. They both require consent and profile. So obviously, kind of ROI and consent. We all know that is the foundation of security and client protections. And then profile is just collecting the basic information about a client. When Ren was referring to forms, our client management system does a lot of forms that track outcomes. So if you are, say, a client walks in and they're seeking health insurance, that health insurance form helps guide the community health worker to track that process and to document it, and to if that client, let's say the health insurance need was identified on February 1st, and then by March 1st they had successfully been enrolled within a health insurance. That health insurance form would help us pull out that outcome and report it. So some of those forms are very similar, but you can see with Pathways compared to navigation, there is far less focus on some of the more long-term needs. So you can definitely still serve somebody within navigation who's pregnant, but that might be a little bit more applicable for a Pathways program where that episode of care is much longer. So it's a lot of those quicker connections to services would be like a social service referral, and that continues to be a bedrock of care coordination for us. Some of the more specific pathways are more so in the when I say pathways, these within the platform they refer to them as pathways, and it's also the name of the program. So there is a lot more documentation, a lot more options for longer term care coordination within Pathways, and less documentation. Because the care coordination can be so much more intensive, the caseload capacity for Pathways is 25, while navigation will be at least 40. We don't expect a community health worker to hold a maximum 100% capacity at all times. We more so look at it about 70 to 80% of that 40 is where we would expect a full caseload, about 32 to maybe 35. That gives a little bit of opportunity for that community health worker to take on more caseload if there is like a surge. But it also allows them to discharge clients too. So we don't want somebody to run at 100% maximum capacity at any given time. Gabe or anybody else from Swatch, any other notes on pathways versus navigation?
I don't know if you said it in here, but we Ren, you've been a part of the discussions, but we just finished kind of like revamping those initial checklists for each of those programs. And the navigation checklist is about that initial assessment that will be required for all clients. The initial assessment is about 10 questions fewer than the Pathways initial checklist at this time. So it's a shorter assessment. And then, yeah, to Basevi's point, we're looking at kind of like a slimmed down number of kind of like referrals out to services rather than tracking like longer term outcomes.
Thank you.
Mhm. There's definitely such a focus from the state right now when it comes to Medicaid and Medicare and health insurance enrollments and making sure people are staying on Medicaid and Medicare. And so that would be a special emphasis of the navigation program and certainly of pathways too. But it's Medicaid and Medicare and health insurance is a heavy focus right now internally at Swatch. Stop sharing this. Anything else? The team will stay on as long as needed. But we're definitely getting down to it. I think it's just a few folks. Sharon or Kesha, I hope I'm pronouncing that somewhat okay. Anything else? Claire, if you want to stick around, we could talk a little bit more about the middle school for sure.
Yeah, I was actually just drafting an email in that chain so that it would get to my executive director and leadership team as well.
Okay.
Keisha, I believe, is still here. So, we certainly could hang out a little bit longer, but I did get that little email written either way.
Okay. Yeah, let me just stop recording here and